Professor David Yernitsky to introduce and welcome our distinguished lecturer of this morning, Dr. Silberstein. Please.
בוקר טוב לכולם ותודה שבאתם. It's a pleasure and honor to introduce Professor Steven Silberstein, who is a leading migrainologist worldwide. Steve was the president of the American Headache Society and was the editor of Wolf's Headache textbook, which is a leading textbook in the field. Steve had learned medicine in Philadelphia, the University of Pennsylvania, worked also at the National Hospital in England and at the NIH, and eventually crossed the Schuylkill, do I say it right? The Schuylkill River, and found himself in the Jefferson University as a leader of the headache center of that university, which is a prominent headache center in the United States. Steve is running many clinical and basic research projects in the field of migraine. I'm sure most of you have seen his paper at the New England Journal 2 weeks ago, which will be obviously part of the upcoming talk. And Steve is also helping us with the device that was developed here for working on migraine, of which Rambam is a partner, and next week is going to help us in meeting with the FDA, and hopefully this will bring some mitigation to Professor Biar's financial headache if we are successful with this device. So without any delay, I'm happy to welcome Professor Steven Silberstein, please.
When we start talking about headache, it's important to be sure you're making the correct diagnosis, making sure nothing else is going on, ordering the appropriate studies, which means don't get an imaging every time somebody has a headache. And all the ultimate goal of headache relief, patients come to us wanting to know what's wrong with them and that we take their complaints seriously. I think it's important to make an accurate diagnosis. I'll never forget a case one of my colleagues had. A patient came into his office with a bad headache. He gave him a sumatriptan injection. The headache got better, but the same day he was admitted to the hospital for a subarachnoid hemorrhage. The teaching point is that responding to a triptan does not diagnose migraine. It diagnoses really a neuroinflammatory disease of the meninges. When we talk about headache, it's not acute treatment, it's not prevention, it's behavioral. It's all three at the same time. There are two major types of headache treatment. Acute treatment to be taken when the pain begins to relieve pain, disability, and stop progression, and prophylactic or preventive treatment to reduce attack frequency, intensity, and duration. When we talk about migraine medications, I divide them into non-specific and specific. I don't say migraine specific because the triptans work for migraine, they work for cluster headache, and they work for subarachnoid hemorrhage. The non-specific medications work for other pain states in addition to working for headache. How do you decide what type of acute treatment to give? What type of migraine does the patient have? Hemiplegic migraine, migraine with aura? How severe is it? How frequent is it? And what are the associated features? But there are general principles no matter what you do. Treat the attack as early as possible. The earlier you treat the attack when the pain is mild, the better the results. Always use non-pharmacologic treatment. That's rest, get out of a noisy environment, use a cold compress. And it's not unreasonable to always have acute medication It's almost always indicated. And the trick is to match the intensity of the headache treatment to the severity of the attack. I think the crucial issue is, in the same patient, there are different types of headache, mainly headaches of different intensity, and therefore you need different acute drugs. You need a headache toolbox. You should have a first-line treatment, a backup treatment, and a rescue treatment. So, for example, if you give a patient a tablet and they don't get better, you don't need them going to an emergency department. You need to give them something or else fails. One of the problems with migraine, its association with gastrointestinal symptoms. About 90% of migraineurs have nausea. Half of them had vomiting. 1/3 of patients with migraine cannot tolerate oral medications. The efficacy of oral medications is lost if vomiting occurs. And there's also the concept of gastric stasis and delayed gastric absorption, which delays the entrance of drugs taken by the oral route. The thing that most of us forget about is rescue therapy. You're giving somebody medication, they're not getting better. How do you keep them out of the emergency room? And this is the one time where I will use an opioid or narcotic, a neuroleptic like prochlorperazine or compazine, or even a short course of corticosteroids like prednisone or Decadron. This is what I call emergency rescue treatment. In 2015, the American Headache Society revised the guidelines for acute headache treatment. And these were our recommendations at that time. For first-line treatment, you should use triptans or DHE if patients have moderate or severe headache. In addition, if the patients respond poorly to lower-end treatment, one should move directly to high-end treatment. The second recommendation is use a non-oral route for migraine associated with severe nausea and vomiting, have a rescue medication, and just as important is to guard against medication overuse headache. The frequent use of acute medicines, on average more than 10 treatment days a month, can lead to increased headache chronification. So what I'd like to do and spend some time today is most of them know about steroids, non-steroids, triptans, and I'd like to give you a preview of some of the new drug targets that are coming down the pike, including CGRP and the selective 1F receptor agonists. Targeting CGRP or calcitonin. Calcitonin is a neuropeptide. The neuropeptide is released with substance P, goes to the receptors, and both the antibodies and the small molecules block the CGRP at that point. It's important to realize that this is a member of a large family of neuropeptides. The family consists of calcitonin, amylin, CGRP, and adrenomedulin. CGRP was originally thought to be involved in the maintenance of vascular homeostasis, but it has a major role in pain control. There are two types of CGRP. They functionally work the same. The A is mainly in neurons. The B is mainly in the intrinsic neurons in the pituitary, in the gut. So most of the drugs we talk about that block CGRP block both of them. So let's talk about CGRP again. It's a neuropeptide. That's a fancy term that means it's a peptide that's made from neurons. Now, very recently, it's been discovered that CGRP is probably only in C fibers and not in A delta fibers, and that probably has to do with its mechanism of action of the antibodies. It's often released with glutamate by the activated trigeminal ganglia, and it results in vasodilatation activation of central nervous system mast cells, which are like basophils, and trigeminal sensory transmission. What's its function? Pain modulation, perception, and sensitization. The best way to look at this neuropeptide is it turns the volume up and down on the pain system as supposedly being a trained transmitter itself. It potentiates substance P release, it provokes nociceptive information, modulates synaptic transmission of glutamate and acetylcholine. In the periphery, vasodilatation, and it may be paracrine. What do I mean by that? It can be released and go to other cells and help it become itself, be synthesized. What's also extremely fascinating in this story is CGRP receptors. There's not a single CGRP receptor. It's a combination of three things, and the language is terrible. It consists of the calcitonin-like receptor, a receptor component protein, and something called the receptor activating modifying protein type 1 called a RAMP1. So to make a CGRP canonical receptor, it's a combination of all three. That becomes extremely important if you're developing a monoclonal antibody against the receptor. It has to go to all three. So, RAMP1 is a receptor activating protein. When bound to the other component, it changes what it does. So if you add RAMP1 to the calcitonin-like receptor, it becomes a CGRP receptor. 2 and 3 enable adrenomedulin function. So this is the canonical CGRP receptor. CGRP, it's the calcitonin-like receptor and the RAMP1 protein. But let's look down here on the amylin receptor. I mentioned earlier, if you put different RAMP proteins on it, you go from a CGRP receptor to a adrenomedulin receptor. Amylin is similar to the CGRP receptor, has the RAMP1 protein, but instead of the calcitonin-like receptor, the calcitonin receptor. This is important. If you think about it, if you're blocking CGRP, the CGRP go elsewhere. And there's very good evidence that the amylin receptor responds to CGRP, and the CGRP receptor responds to amylin. And what it's important to talk about the amylin receptor because it's the same concept. It's the calcitonin receptor plus the RAMP1 protein. And the role of amylin is under intense investigation now. And there is a drug called pramlintide, which is an analog which is used with insulin because one of the ways it works, it's secreted from the pancreas along with insulin to modify weight and control of glucose. So the question is why? Why is this so important? Because people are talking about the safety, the crosstalk, and why everything doesn't always work. And for all intents and purposes, there are two CGRP receptors. CGRP goes to the canonical CGRP receptor and activates the amylin 1 receptor, and it's equally potent to amylin. In contrast, adrenomedulin and amylin activate the CGRP receptor, but much less potently. And here's where it gets important. All antagonists inhibit CGRP function at CGRP receptors, but it does differently things. The anti-CGRP receptor blocks the canonical receptor, leaving the other receptors intact. But if you have an antibody to CGRP itself, it blocks the ability of the CGRP to go to all the effectors. This is important when we talk about long-term safety. So to reiterate, this is the canonical CGRP receptor, which has a RAMP1 protein and a calcitonin-like receptor. This is the amylin receptor with the calcitonin-like receptor. But if you go to the pharmacology, Japan, which I'll talk about in a minute, which is the GPAM, which is a selective CGRP receptor antagonist, mainly goes to the canonical receptor. Talcagipant goes to both, and a drug called AC-187 particularly goes to the calcitonin receptor. Now, what's the relevance of CGRP to migraine? It's pretty simple. If you infuse CGRP, it triggers migraine after a delay. Extremely important. So it's not triggering headache, it's modulating the system. If you measure the levels of CGRP during migraine, they increase, and if you give a triptan and get headache relief, they go down. Triptans work by blocking the release of CGRP. We have a whole new class of CGRP receptor antagonists which actually block the release of CGRP, whether you're doing an antibody or a GPANT or blocking CGRP itself. And what's extremely interesting is the fact that the CGRP receptor blockers are not direct vasoconstrictors. So the first drug that was developed by Merck is a drug called talcagipant. I'm going to point out two things. One, it's about as effective as zolmitriptan, and the placebo response is lower, and two, practically had no side effects. However, in the clinical trials, it was discontinued because some patients developed liver function abnormalities. And for a while, the entire field died. But at this point in time, new GPANTs are in development using a different structural background. And Merck has two of them, one for acute and one for prevention. Biohaven has two in development, and Teva may also be acquiring GPANTs. So we will then be having small molecule GPANTs, which have no side effects except for the one which is probably related to the backbone of the molecule and not to the mechanism. This is an older study from 2016 showing one of the newer drugs, ubrogepant, placebo % response at 2 hours in the therapeutic range, about 40 to 50% of the patients had a pain-free response at 2 hours. So this is on the way. This is in development. Clinical trials of ubrogepant are underway for acute and the second one for prevention. Let's move on to preventing headache. First and foremost, when should you consider migraine prevention? It's not one thing, it's multiple. If the patient's life is interfered with despite appropriate acute treatment, prevention is valuable. If the attacks occur more often than once a week, that's the risk factor for developing chronic daily headache. And we would suggest it. If the acute medicines don't work or overused or can't be used, prevention should be considered. Patient preference. There are certain people in certain occupations who cannot afford to have a headache. If you're a neurosurgeon, you cannot have a migraine if you're pecking apart somebody's brain. If you're an athlete, you cannot have a migraine attack in the middle of a game. This is reasons for prevention. And if you have hemiplegic migraine or migraine prolonged aura, basilar migraine, or migrainous infarction, these are other indications for prevention. There are many different medications for prevention used throughout the world. Most of them are used based on other indications and do not have specific indications. The beta blockers, some of the antidepressants, and the anticonvulsants are most commonly used in the United States and other parts of the world. Onabotulinum toxin A is used for chronic migraine. A number of years ago, excuse me, we developed evidence-based guidelines for migraine prevention. They are currently under revision. But what did we decide? Based on scientific evidence, and this is crucial, a drug could be the best drug in the world developed for another indication, but if no clinical trials have been done, it does not have good level of evidence. So for example, if you're rating penicillin in the treatment of pneumonia the level of evidence would be possibly effective because there are no well-designed placebo-controlled trials. It's always important to realize that. So, level A effective, divalproex, topiramate, 2 beta blockers, probably effective, amitriptyline, venlafaxine, which is the SNRI, 2 more beta blockers, possibly effective, candesartan, lisinopril, clonidine, carbamazepam, pindolol, and cyproheptadine. But what's surprising, inadequate, or conflicting includes drugs we often use, such as the calcium channel blockers and gabapentin. And clearly not effective are lamotrigine, acetabutal, oxycarbamazepam. So many of the drugs that we almost use routinely, like verapamil, have very little evidence. And the evidence for gabapentin is low. I did a study a couple years ago of a gabapentin pre-drug. We thought we mixed the vials up because the placebo did better than the active drug. So I think gabapentin is the drug we widely use for everything, often in the absence of evidence or with evidence that it doesn't work. How do you decide what medicine to pick? What type of migraine it is? How effective is the drug? It's not only the evidence, but the clinical experience. What are its side effects and safety? What else is going on and what the patient wants? I think I put this in because many of us have been using topiramate or Topamax for lots of indications, and everybody believes that topiramate increases the risk of kidney stones, which I included these 2 recent papers. Shen looked at a nationwide population study comparing patients with topiramate with controls. This is an epilepsy, not a headache population, and showed that the incidence of kidney stones in topiramate was not different from controls, and kidney stone-free survival was the same. What I'm telling you is, in patients with epilepsy without migraine, topiramate does not increase the incidence of kidney stones. However, if you take a look at migraine, migraine itself increases the risk of kidney stones. So if you have migraine compared to controls, you have a 60% greater chance of having kidney stones. If you take topiramate plus migraine, your risk goes from about 1.56 to about 196. So my advice to you is all your migraine patients should be considered to have kidney stones as a potential. And the additional risk from topiramate is much less than the risk from migraine itself. Something new. When we talk about migraine, it's important to talk about comorbid and coexistent conditions. A coexistent condition is anything else that's present. A comorbid condition is present more often than by chance. Therefore, we know that there's angina, mitral valve prolapse, patent foraminal valley in patients with aura. There's more epilepsy, essential tremor, and Bell's palsy. There's more depression, mania, anxiety, and panic, colitis, irritable bowel. Some people claim irritable bowel is the migraine of the gut. There's allergies and asthma. So when you have a patient with migraine, they are more likely to have these other disorders. So what do you do? In the old days, we would say take 2 for 1. So if you had a patient with hypertension and migraine, you give them a beta blocker, but nobody's recommending, at least in the United States, beta blockers as first choice. So try to pick one drug if it's the best option for both. Be careful about one drug aggravating the other disorder and vice versa. So what we tend to do now is pick the drug for the disorders and give co-therapy unless one drug is the best drug or close to the best drug for both disorders. So where are we going and what's happening? We have now drugs in development. There are antibodies to calcitonin gene-related peptide, and there are antibodies that target its receptor. Just a brief review, because I can never remember that. An antibody is an immunoglobulin. It's a glycoprotein which has two identical heavy chains and two light chains. Those are the heavy chains, these are the light chains. And the business end of the molecule here is where the antibody binds. Now, in the human being, there are different types of antibodies, A, D, E, G, and F, G and M. If you get an infection, the first antibody to appear is M. Later in an infection, you get IG. This is what they look like. This is the first to appear. This is the one we're going to be talking about, which is the major antibody in human serum. The therapeutic monoclonal antibodies are all made from IgG, of which there are 4 subtypes. The reason this is important is when you hear the advertisements, if you work in other fields and use antibodies, you're told to worry about tuberculosis, you're told about getting infections of the central nervous system, particularly you're in the field of multiple sclerosis. If you're in the arthritis field, you worry about all these infections. It's not the antibody that carries the risk. It's the way the antibody is designed. So for example, IG1 is designed to kill cells. At 2 and 4 are less effective. So these antibodies are bioengineered. So the bottom of the T, the antibody, is the part that binds to the cell receptor. You can put genetic mutation to prevent that from binding. And it no longer has the ability to do that. So what these antibodies have been done is the interactions have been eliminated, and you really have a pure blocker of CGRP or its receptor. The other important point about antibodies is over the years, there used to be mice, and then 65% human, more than 90% human, or 100% human. And all of the current antibodies are either humanized or human. And if you read the label, a humanized antibody is Zumab. The only reason I remember that is like a zoo and an animal, where the purely human antibody is Umab. So all of the current therapeutic antibodies today are Zumab or Umab. How do they work? Well, natural antibodies target and destroy foreign proteins. That's why we get injections to build our antibodies up. Therapeutic antibodies can destroy target cells or alter target cell function without cell destruction. That's the direct mechanism. Indirect mechanism is to use functions in the body to induce complement or cell-mediated toxicity by having the antibody bind to its receptor on the immune cell. What's the difference between a small molecule and an antibody drug? First and most important is the small molecules are small, and the large animals are about 100 to 200 times larger. The small molecules can be given orally. The big ones need to be injected. The small ones can enter the blood-brain barrier. The big ones can't. They're excluded. Interestingly, small molecules have a half-life of minutes to hours. The monoclonal antibodies can have a half-life of a month. The reason is they are taken up by reticular endothelial cells, bind to the same receptor that's responsible for transport of the fetus, protected, and leave. Antibodies are manufactured in tissue culture. Small molecules are chemically made. What are the benefits of therapeutic antibodies in general? There's no toxic metabolites. They break down to amino acids. There's no issue with drug-drug interactions. Because of their long half-life, they're ideal for chronic disease. If they're designed properly, there's no off-target toxicity, and the tolerability is usually excellent. But what is now being developed in the way of monoclonal antibodies in the CGRP space? The first is by alphabetized the older drug, epinzumab, which is the humanized rabbit IG1. The second is the Amgen drug, erenumab. It's 100% human. Lilly, galcanezumab, it's a humanized antibody. And the Teva drug is rivaroxaban, which is humanized. Most of the data now is in the public domain. Epinzumab is an antibody which is different because it's manufactured in a yeast system. Like all of the antibodies, it's got a very long half-life. And since it's given intravenously, it has 100% bioavailability. I think what you need to realize, and something I didn't realize, is the following. If you give an antibody intravenously, you get therapeutic levels immediately. If you give an antibody by injection, it has to go through the lymphatic system, taken up, and then dumped through the thoracic duct. So IV, you get Tmax within an hour. With injections, it might take a week. So it's not the difference in the antibodies, it's the difference in the route of administration. Just one of the quick trials. This is one of the, where we looked at different doses of the older drug given at a baseline and then given 3 months by infusion. And the primary endpoint, a little bit different, a 75% reduction in migraine days was achieved by a third of the patients at week 12. And if you look at the 50% responders, pretty typical. This is the 75% responder rate. I think the two interesting things about the antibodies are, we used to say it takes 2 or 3 months to get benefit. With the antibodies, the benefit starts to occur immediately as soon as it gets in the bloodstream. So you can predict fairly quickly whether or not you're getting benefit. So it works with a single IV administration. Responses are actually as early as a week, and the responder rate seems to be quite high. So far, there have been no significant adverse events in any of the trials other than the site of injection. That was an antibody against CGRP itself. The second antibody I'm going to be talking about is the erenumab, which is a monoclonal antibody against the canonical CGRP receptor. And how they designed it is very interesting because it binds to both the RAMP1 and the calcitonin-like receptor. This is the paper that was published November the 30th in New England Journal, showing the effects of placebo, erenumab, the 2 doses. But again, I want to point out to you, by month 1, there was no earlier point that the effectiveness was reached. And patients who received either dose, and this was again given intramuscularly, had a significant improvement. The adverse event profile was similar to placebo, and the only major adverse event was site on injection. Simultaneously with that was a phase 3 trial on prevention. Now, again, I have to excuse myself. I'm involved in many of these papers, so I'm trying to be as honest as possible. And basically, in erenumab and chronic migraine, using the 50% reduction, both doses close to 40%, 23% with placebo, which is what we have been seeing all along. So we concluded the drug is safe, the drug is effective, the drug works quickly, not as quickly as the intravenous preparation because of the delay in absorption. The side effects were similar to placebo except for injection site reaction. The third antibody is galcanezumab. If any of you are antibody experts, you would be amused that they use IG4. IG4 has arms that swing around and rapidly lose their ability to function. They made a mutation so that doesn't happen. Again, there are a number of trials showing its effectiveness. and basically looking at the 50, the 75, and the 100% response rates in episodic migraine, it's very similar to the other drugs. So you're getting the picture here that these drugs are more alike than similar, fast action, same side effects, similar efficacy, 50, 75, and 100% response rates. So, in conclusion, this is the Lilly drug. It works for episodic and chronic migraine. It works quickly. It works consistently. And the AEs are low. The last drug I'm going to talk about is the Israeli drug, Preventive, made by Teva. This is, again, a humanized antibody. And what's interesting about this trial is the other trials with the IV gave it every 3 months. The other trials with subcutaneous gave it monthly. This is the unique design where we gave it either monthly or every 3 months, looking at the effect. And this was published November 30th, the lead article in the New England Journal. And essentially what we showed is we looked in reduction in headache days right here, 2 different dosage, and reduction in migraine days. And for all intents and purposes, whether you gave the drug monthly or quarterly, you had the same benefit. So in this trial, we were able to duplicate the long-term efficacy of giving it intravenously, showing that Preventive worked both ways. So we concluded it was superior in both endpoints, given monthly and quarterly, and there were no significant treatment-related adverse events except for injection site reaction, which is what we're seeing with all the antibodies. So what can we conclude? The antibodies to both CGRP and its receptor are effective for migraine prevention, both acute and chronic. Cluster headache and post-traumatic studies are currently under the way. They're safe for migraine prevention, and there are very few adverse events except for injection site reactions. The last thing I want to talk about this morning, I still have a few minutes, is neurostimulation. It's interesting if you were a fan of I, Claudius on BBC. His physician, Scribonius Largus, was a staunch advocate of neuromodulation, and that's his book on the left, and to quote unquote, translation from the Latin, to immediately remove and permanently cure a headache, however long-lasting and intolerable, a live black torpedo is put on the place which is in pain until the pain ceases and the part grows numb. There are a number of different modalities. Occipital nerve stimulation has been abandoned, but will be coming back with new devices. The first thing I'm going to be talking about is transcranial magnetic stimulation. This is the new device. It fits in the back of the head, and it is designed in such a manner, I believe it's going to be difficult to stimulate any other parts of the head. We did a study a number of years ago, 200 aura patients, in a double-blind, placebo-controlled trial. And what we found is the following. Pain-free at 2 hours, close to 40% with the device, closer to 20% with sham, and it persisted. And we had very few, if any, adverse events. It's easy to make a sham for this device, because if you put the device on your head, all you hear is the noise, so you can just create the noise without the charge. Adverse events, very similar to placebo. We actually have found that it's an unpromising treatment option. It's safe, it's well tolerated, and the United States is approved for both acute and preventative treatment of migraine. The major problems with the device are cost, and it's bulky, and you have to take it with you. It's like a brick in terms of weight. I wanted to talk next about a local device. And we have the genius behind it. I'm going to show his paper sitting right in front of me. This is a TENS unit electrical stimulation, two-way wireless smartphone controlled, which means the treatments can easily be controlled, personalized, and cloud connected, disposable and low cost, small, thin, and comfortable. And this is the paper that was published from Rambam University in Neurology last year. Non-painful remote electrical stimulation alleviates episodic migraine pain. And the data from the paper, this was a double-blind placebo-controlled trial of close to 90 patients, treated onset, adjusted through your smartphone, and the typical data was collected. And these are the results: placebo response, the device, and looking at data from triptan. So pain decrease from moderate to severe, 24% with placebo, 76% with the device, as a standard 60% roughly that. And if you look at different responders at 2-hour post-treatment, these are patients with the device, placebo, sumatriptan, device, placebo, sumatriptan, pain relief, device. So based on this paper, which clearly showed a statistically significant benefit without significant adverse events, the device is going to be taken into larger trials. The second TENS device on the market is the Cephali device. This is the original design. The newer design is just limited to the forehead. Its approval was based on a study by Jean Schoenen, who actually showed it took 2 months of treatment to separate from placebo. But on the basis of that study, it's now approved in the United States for both episodic and chronic migraine treatment. Vagal nerve stimulation. Anybody is interested, there's a series of 4 papers that I wrote with one of my fellows to cover the basics of vagus nerve, its biology, and its use. The device we've been using lately is a handheld, external, non-invasive device called the GammaCore device. And the way it's worked is you put it on your neck for 120 seconds. And what's interesting is if you do that, and you can able to adjust it there, the current. If you put it on, you adjust the current to comfort. If it's uncomfortable, you lower it, stays there for 120 seconds. You can repeat it on the other side. And what we found is that there are prophylactic studies in migraine and cluster. Now, at this point in time, it's FDA approved for the treatment of cluster headache, and we're waiting approval for migraine. So why do we care? As Albert Schweitzer once said, pain is a more terrible lord of mankind than even death itself. Thank you.